We couldn't.
Welcome. And we have lots of interesting pieces. So you will get a good deep presentation. Okay. So today we are going to talk about neonatal fever. So before we begin, I have a couple articles. So one is the pediatric Cincinnati protocol, and that's what we use for neonatal fever, but that also has guidelines up to 2 months of age. Then the second article is from American Family Physicians, so that pertains to you guys. There's just a difference that we'll talk about later, but we will follow for peace purposes the Cincinnati protocol. So before we begin, has anyone here had a neonatal fever, a case of neonatal fever? Yes. Okay, so Jen, if you want to tell us what you remember, that kid presented or how you managed that patient. Just whatever you remember. Fluid, okay. Do you remember what you did for the baby in terms of workup?
Like spinal tap, like sepsis.
Okay. So why do you guys think that you do so much work for a neonatal fever?
Because they're fragile and they can't talk. Plus, like, if you specific like an adult, you just have to test everything.
Yeah. Okay, so if a 15-day-old presents to the ED and has a temperature of 38.4 Celsius, which is 101.4 Fahrenheit, what would you guys do next and why? You can just say your analysis is yeah. History. Yeah. So yeah, most important thing is just always safety. But yeah, spinal tap viewing. But so what is neonatal fever? So what is a neonate? Different sources will call a neonate a different age. So Cincinnati will call a neonate any baby under 28 days or under, but a lot of other pediatric sources will use 30 days. So Dr. Abuzar and I can sit down and we can kind of decide what we will consider a neonate here. But just because of the Cincinnati protocol and that's what we most use, I called it 28 days. And a temperature of 38 degrees Celsius or higher, which is 100.4, will be a fever in a little baby. And of course, we always want to measure the rectal temperature. That's the preferred way of measurement because it will be the most accurate. So if you have a mom who's got a temporal temperature, if you take an axillary temperature, the rectal temperature will usually be higher and a more accurate temperature.
Question.
Yes.
So they had 100.3. Why can't you when I look them up?
You would have to get a history, of course, because there could be other clinical manifestations. But I would get a history, but you're not obligated to do a full work. So why is neonatal fever important? So you guys already said some of it. So a neonate cannot talk. A neonate cannot tell you what's wrong, what's bothering them. And if you miss something, so a neonate that has a fever is at a high risk of having a serious bacterial infection, which we'll talk about what a serious bacterial infection is a little later. And so if you miss a serious bacterial infection, the baby will probably have a poor outcome. And so we don't want to miss a serious bacterial infection in any febrile neonate. It's difficult to gauge what's going on in a febrile neonate. You have to do a workup. Okay, so we have some differentials of what could cause a neonatal fever. Do you guys want to just sort out whatever you remember or know? Sepsis. Sepsis. Urinary infection. Yeah. Urine infection. Meningitis. Yeah.
Fever of unknown origin.
So neonatal fever would really be fever of unknown origin until you can figure out what's going on. So actually, they do call it Cincinnati right here, fever of uncertain source. But unknown origin, you have to have a certain number. But, anything else that could cause the neonatal fever? So we did the big one, sepsis, UTI, and meningitis. Those are the big ones, the ones you worry about because they have they could have the highest morbidity mortality. But anything else common? GBS. Yep. So I would go, GBS can cause lots of things, sepsis. Any, Yep, URI. So common things like a viral illness or pneumonia. Okay, meningitis. So anybody know in a neonate, common bacterial causes of meningitis?
E. coli.
Diphtheria. Yep. Not so common anymore, but and
Hemophilus.
yes. Yeah. So Hemophilus is more common, or is it less common now with the vaccination? Yeah. And even streptococcal meningitis is not as common anymore. And then enterovirus is called a viral cause of meningitis. So herpes infections is also very important. We don't want to ever miss a herpes infection on a neonate because of significant morbidity and mortality. So HSV can cause localized or disseminated infection. So localized infection would be in eyes, and then disseminated infection would involve organs, so things like hepatitis, pneumonitis, CIC, and then meningeal encephalitis would be a localized infection. UTI. Common causes of a UTI in the neonate, E. coli, and enterococcus. Bacteremia, sepsis, cellulitis, you can also see in a neonate. And abscess, osteomyelitis, you would also see GBS causes some of these skin infections, skin and bone infections. GBS, yeah.
Are we going to get access to your slides?
I don't know.
You can give it to this house.
Oh, yeah.
You can send it to her and then
Aren't they awesome?
Yeah, they're
The
awesome.
slides,
Yeah.
but even the whole even the whole setup, like they're very like
How are we going to
stylish.
I'm not doing anymore.
No. But now you guys have to do as well. You mean, yeah. Stylish.
Yeah,
Style, yeah.
So some of the how common different etiologies are. So the most common etiology of neonatal fever, and really any fever in pediatrics, is actually a viral cause. Viruses are very common, lots of different viruses, respiratory viruses especially. The most common bacterial etiology is a UTI, followed by meningitis, sepsis, abscess, pneumonia. So I have a little chart, viral UTI, and then bacteremia, sepsis, and meningitis. So there was a study in a pediatric journal that showed 12 to 28% of neonates that presented to a pediatric ED. So this wouldn't apply to our ED because it's not a designated freestanding pediatric ED, had a serious bacterial infection. So in this study, those babies had bacteremia, gastrocellulitis, osteoseptic arthritis, meningitis, pneumonia, and UTI. And that's from the Cincinnati protocol paper that you guys should all
That's
have.
the meningitis, there's bacterial meningitis.
And viral meningitis. But this would be a bacterial meningitis because it's under the serious bacterial infection. But enterovirus could cause neonatal meningitis. And so can herpes. And those are viral. Oh, I don't know. Okay, so febrile infants will have very few symptoms to guide management and diagnosis. So you might just not know what exactly is going on in a neonate that comes into your clinic or the ED and has a fever. So what are some questions that you guys would like to ask the mom or the dad that brings in the baby? What are important things to ask in a febrile neonate?
Baby get prenatal care.
Yeah. So
Are they feeding, peeing?
exactly. So a baby really sleeps, eats, and goes to the bathroom. So any changes in their sleeping pattern, are they more irritable or are they lethargic? An irritable baby is more significant for meningitis, and a lethargic baby is more significant for herpes. Let's see, and then any changes in stooling or urinating, so diarrhea. And maybe the urine might be different and then yeah. Yep. So how hydrated are they? Are they making tears? Are they still urinating? So fever, first of all, how high? You always want to ask the mom, how high was the temperature? Where did you measure it? Did you give any antipyretics? Usually parents don't do anyway, but you should ask anyway. Anytime you have a pediatric fetal patient. Any change in feeding? If they're not interested in feeding anymore, that means something is going on. Are they irritable or lethargic? Any seizures? You can see this with herpetic meningitis or even bacterial meningitis. Any change in cry? So a meningitic baby has a very specific cry. It's kind of a high-pitched, hoarse cry. And once you hear it on a meningitic baby, you won't ever forget what that cry sounds like. But it is different from their normal cry. It's kind of high-pitched and hoarse. Any URI symptoms, so runny nose, congestion, difficulty breathing, or anything viral or respiratory. Any swelling of the skin or joints, stick contacts, important. Any vomiting or diarrhea. Okay, so physical exam, head to toe. So always the general physical exam is important. How does the baby look? HEENT, so the anterior consonant in meningitis will be, how will it be? Bulging, yeah. And you will actually feel that in meningitis. It really is bulging. It's not flat, sunken, dehydration. You want to look at the eyes, any signs of conjunctivitis, or babies could even, I haven't seen a neonatal orbital or periorbital cellulitis, but it could happen. Any signs of otitis, very not common in a neonate. Congestion, rhinorrhea, does the cry sound different, any cough, any neck swelling. So the meningeal neck signs you see in older kids, like Carnigs and Residency, you cannot see that in a neonate. Lungs, are there retractions, crackles, or bronchi? So this would lead you more to a viral respiratory infection or even bacterial pneumonia. And then the lungs just murmur, tachycardia, capital pulses. So see how the perfusion of the baby is. Does the baby appear to be in shock? These pulses not well perfused. Any signs of omphalitis? Is the baby circumcised? If they're not circumcised, they have a higher risk of UTI. Any cellulitis, abscess, rash, joint swelling, and then for neuro, are they irritable or lethargic or acting like a normal baby?
I have a question. So for omphalitis, is that from like inflammation from an autopsy?
So omphalitis is actually infection of the umbilicus. So the umbilical stump has already fallen off, but the actual it could still be attached. Actually, it's usually attached. But around the umbilical stump, you have signs of infection. So it's erythematous, it's swollen, and that can happen sometimes if you do a tub bath, if there's water or soap or anything that can contaminate that area. So when the umbilical stump is in place, we don't recommend tub baths, only sponge baths. But that is caused polymicrobial, and you treat it with heavy-duty antibiotics. But you'll see redness, swelling, it'll be painful when you touch, just right around the umbilicus. Okay, so how do we diagnose what is causing the neonatal fever? So every single neonate with fever will get the full sepsis workup. So what is the full sepsis workup? We already talked about some of these: CBC, blood culture, UA, urine culture, and lumbar puncture. So we talk about pan cultures: blood, urine, and CSF. So there's a picture, I don't think works, but normal CSF is clear. Turbid CSF is cloudy. So whenever you do an LP and you get cloudy fluid back, you can be pretty sure it's a bacterial meningitis in a neonate. Xanthrochromic has red blood cells, and that's usually seen in HSC, but it doesn't have to. It's not any more pathognomonic for HSC in the neonate. So a UA should be via catheter because it'll be the most sterile method of obtaining a urine culture, and then CSF. So we have different tubes to collect CSF. It's about 1 milliliter each tube. So the first fluid that comes out is usually the dirtiest, and as the fluid keeps coming out, it becomes cleaner. So the first tube will be culture, always. and then protein glucose, and then the last tube, which should be the most sterile fluid, will be cell count. And then if you think there is a possibility of HSV, and some pediatric centers will just send off the fourth tube to test for HSV PCR, but the fourth tube would be for HSV. If you have enough fluid in the lab and you've done a gram stain and you've done a cell count and you see that there is pleocytosis, which means white blood cells in the CSF, then you can have that fluid sent off for enterovirus. Because enterovirus can cause pleocytosis, but the gram stain will be negative. Why? Because it's a virus. So the article from the American Family Physician that I handed out recommends a chest X-ray for all female neonates, but the pediatric sources with symptomatic protocol only recommend a chest X-ray if baby is symptomatic. So just because the neonate is febrile, you do not do a chest X-ray unless they're symptomatic. This applies to bronchiolitis too. So if you're pretty sure you have a febrile neonate with bronchiolitis during bronchiolitis season, you do not have to do it. Unless baby doesn't improve or gets worse. So if there is diarrhea, we would do a stool culture. Now, if the baby, the neonate, is unstable and you cannot do an LP, it's okay. And the most important thing is to give your first dose of antibiotics, and we'll talk about that. So sometimes maybe this year during bronchiolitis season, we'll get a couple of neonates that are admitted for bronchiolitis, and they have a fever on the floor. These babies still need a full sepsis workup. So maybe we'll do some LPs. Not great for the baby.
If there's
no red
blood
cells.
no blood.
Okay, so general consensus has come up with what is a normal WBC count. So a normal WBC count will be 5 to 15. Now remember, the newborn up until 24 hours, 24 hours could have an elevated white count. But these are usually babies that have gone home after birth and then have come back with fever. So 5 to 15 is normal. So if they have leukopenia or leukocytosis or an elevated ANC, so they have lots of neutrophils and they're at risk for an STI. So also, general pediatric consensus has said that if a baby has less than 20 WBCs in the CSF, they're at low risk for meningitis. If they have greater than 20 WBCs, they're at high risk. I don't know if you guys have Harriet Lane or if you guys use something else, but Harriet Lane has a table in the back that has all the normative values. Oh, I always have my Harriet.
Oh, yeah. Oh, Harry, okay, you're all getting Harry Lane.
Really pretty good. She, I think it's awesome.
Oh, no, I have a couple of them. They're really old. We always had one every year in residency. I would get a new one, yeah. Right?
The back is normative.
I still have mine.
I still have
Oh, do you? It's a great book. I'll look it up. I'll show it. You guys, you have heard of it?
We've seen it in the pediatric ward.
Oh, okay, all right, okay.
Yeah.
Yeah.
Harriet, we love our Harriet. So
Yeah.
it has all the normative values for different ages of babies. But 20 is what the PEDS community has come up with for high-risk low-risk meningitis. And then, of course, bacterial meningitis has high protein. Why? Anybody know why? You have high protein in bacterial meningitis. That in bacteria are making protein, releasing protein. And then you have low glucose. Why? That's your eating it. Yeah. And then UA should have should have less than 10 WBCs, and of course, no leukocytosis or nitrate. So that would be a sign of bacterial UTI.
Sorry, 20 in the last slide. You mean 20,000, right?
20,000
Okay, just
per
making sure. Okay.
milliliter.
Okay.
Okay, so how do we manage these babies? So all of our babies are admitted with neonatal fever. All neonates with fever get admitted. They all have the full sepsis workup, and they all get antibiotics. So we want to cover our common organisms, and we'll talk about that in the next slide. But as soon as the all three cultures are done, you give your first list of antibiotics, and ideally it should be done in the ED. You don't delay antibiotics to do an LP if you cannot do an LP. So we can do ampicillin and gentamicin, or ampicillin and cefotaxime. And we don't use ceftriaxone in neonates because it can cause biliary sludging. So you have increased bilirubin and there's a risk of kernicterus. So we use cefotaxime. Now, amp and gent is not used as commonly in the neonate that has gone home after birth and come back to the hospital for admission because with gent you have to follow drops and peaks and it's just a little bit more poking the baby. So we do amp and cefotaxime. And then any baby that has an HSV PCR result pending in lab should be started on empirical and acyclovir treatment. So because lots of different research studies have not yet been able to predict which neonate has a serious bacterial infection, all febrile neonates are hospitalized. They get a full sepsis evaluation and IV antibiotics. So ampicillin, very important. Enterococcus and listeria need ampicillin to be killed. So not very common listeria anymore, but enterococcus can be seen in a UTI. So if you have a baby with a UTI who's really still very febrile and the culture hasn't grown anything after a day or a day and a half, you can always add them. Well, ampicillin should be added anyway, but in older kids too, you want to think of enterococcus if they're not already covering with ampicillin. And then it also covers our strep and our gram-positives. Gentamicin covers your gram-negatives and it crosses the blood-brain barrier, as does cefotaxime. So cefotaxime can also cross the blood-brain barrier, so it's good for meningitis. And then importantly, E. coli is mostly resistant to ampicillin. So next time you guys have like E. coli UTI, just look at the sensitivities and you'll notice that it's usually resistant to ampicillin. So cefotaxime is good for AMP-resistant E. coli. So this is from the Cincinnati protocol. So this is the mainstay of this presentation. So all febrile infants, febrile neonates under 28 days, or 30 days, we can kind of decide as a team what we'll choose as the neonatal age. Should be hospitalized, have a full sepsis evaluation, and have IV antibiotics. So here you can see that you have your febrile baby. If they have a sign of focal infection like an omphallitis or a cellulitis, then you don't follow this protocol. You have to treat according to whatever infection they have. But if they don't have a focal infection, then you have to do the full sepsis workup. So CBC, UA, urine culture, blood culture, LP, and then chest x-ray if they're symptomatic. If they have pleocytosis, so elevated white count in the CSF, but the gram stain is negative, then you think of viruses, because viruses would have a negative gram stain, right? Because they're not bacteria. So then you have to consider HSV, maybe enterovirus too. And then you admit and you give AMP, gent, or cefotaxime. Let's see. Okay, so then in that little box, HSV shouldn't be performed routinely on babies unless you really think that there is for HSV. And we'll talk about HSV too because that's important in the neonate. So sometimes you get a baby who's been started on antibiotics, but they haven't had an LP. Either it wasn't able to be done successfully or the baby was too unstable. So what can you do? Well, later, eventually, you have to try it again in LP after admission. If you really can't, then you can stop antibiotics after 2 days and watch them off of antibiotics and see how they do. But if you are able to eventually get an LP and you see that they do have pleocytosis, I don't know if we can do it here at this lab, but you can add real-time PCR DNA sequencing for rRNA. So HSV is a terrible disease. So this is skin, eye, mouth, cutaneous, localized HSV infection. So whenever you do have HSV in the neonate, so a baby develops this, then you have to do comprehensive testing. So you do swabs from the nasopharynx, conjunctiva, and anus. You have to tap the baby and send the CS up for HSV. You'll send the blood for HSV PCR, and if any fluids are present, you can unroot the fluid and send that also for PCR. Then we get a CBC. Does anyone know why CBC is important in HSV? It can cause thrombocytopenia. And then we do BUN and creatinine. Anybody know why that would be important? So the treatment for HSV is acyclovir, and acyclovir can cause renal toxicity. It's not the HSV itself that causes renal toxicity. And then our AST, ALT. Anybody know why? Hepatitis. That's known to cause hepatitis, so something to follow and look at. So another picture of neonatal HSV. So HSV in neonates, neonates that are at greatest risk are those that are born vaginally to moms that have risk factors for primary infection with HSV. So it's their first time having HSV infection. So what moms do you think would be at risk for having a primary HSV infection? What would their risk factors be? HIV? Sure, so maybe co-STIs. Yeah, multiple partners, change in partner during pregnancy, a mom who's noticed any sores, a mom who has received oral sex late in pregnancy from someone with oral sores or oral HSV, and sometimes a mom who's had multiple yeast infections could be at risk, or a mom who's been diagnosed with UTI, because urinary retention can be mistaken for an HSV infection. So vaginal delivery is where you have your transmission of HSV. So moms that do have sores or vesicles will be delivered, babies will be delivered C-section. So these babies are pretty sick. They have severe illness. They can be hypothermic. They can be lethargic, seizures, hepatosplenomegaly. They have a very bad hepatitis. They can have pneumonitis, conjunctivitis. They can go into DIC, encephalitis. So they'll be thrombocytopenic. They can be thrombocytopenic, have hepatitis, and they will have pleocytosis. But remember, Gram-stay negative. And if you are worried for HSV, you should do an HSV PCR. And if you do an HSV PCR, you start acyclovir empirically and fluids too to help prevent relapses. So the main question now in neonatal fever is how long do we admit for? So standard length of hospitalization is 48 hours. It's the 48-hour rule-out process. But now there's been lots of research done to see if we really need to admit fetal neonates for 48 hours. And a lot of big centers that can do rapid viral testing only watch for 24 to 36 hours. So let's see what becomes the new guideline. So these different studies have also looked to see if they can kind of predict which neonates will be at risk for a serious bacterial infection by looking at low risk versus high risk. So this is low risk criteria for older infants up to 2 months. And that's here in Cincinnati because this one talks about infants 0 to 2 months. But studies have used this same criteria and have extrapolated it to 0 to 1 month olds. So we're trying to see if maybe using low risk criteria in a fetal neonate can kind of predict who will have a significant serious bacterial infection or not. A lot of writing here, I know. So this is one study, one of the more popular studies looking at how long to admit for. So in the past, this 48 hours came from studies that were done on neonates that included NICU babies. NICU babies usually have lines, and they usually can grow yeast or staph epidermidis. Yeast takes a long time to grow, so when you look at NICU babies, then your length of hospitalization will be longer, and so you will recommend to admit and observe babies longer. But recent studies have excluded NICU babies. So this study had the objective of determining the risk of having a pathogenic bacterial culture in either blood or CSF. They didn't look in urine because the medical staff did not have to be called with positive urine culture, so sometimes it would take time for them to find out that their baby has a positive urine culture. In neonates, after 24 hours. So they looked at 1,145 infants under 30 days that had blood or CSF cultures drawn in Northern California for a long time, 1999 to 2010. And they used the high and low risk criteria in their neonates. So they said that high risk infants were leukopenic or had leukocytosis and had elevated BAMs. So they had 1,876 blood and CSF cultures, and 79% were hospitalized. And of those that were hospitalized, 45% were for fever without a source. So neonatal fever, normal neonatal fever, no focal infection. 2.7% of those babies had pathogenic cultures, and 0.5%, which was only 6 babies in their study, had a time to notification of greater than 24 hours. So very few babies had greater than 24 hours of a time to notification, which was the time the sample was collected to the time the medical staff was notified. So of those 6 babies, 0.5% all had fever without a source and high risk criteria. So no low risk criteria baby had a time to notification greater than 24 hours. And then a certain percentage of the high risk babies had growth of 24 to 48 hours. So it's still a low percentage that had growth after 24 hours. So the study was trying to see if a baby has low risk criteria, can you maybe discharge them home sooner? Because in their study, none of those babies had a positive pathogenic culture after 24 hours. So they concluded that maybe low-risk infants don't need to be hospitalized for 48 hours for just bacteremia or meningitis. They didn't look at urine cultures. Then they found that the mean time to notification was 24 hours plus or minus 17 for pathogens, and the median time was 19 hours for pathogens. But contaminants will take longer to grow, but we don't worry about contaminants. We only worry about true pathogenic bacteria. So I think, yes, so we already discussed this. So the previous studies have included NICU babies, which can grow yeast from lines, and that will take longer. So previous studies have suggested to watch and give antibiotics for a longer duration. But if we don't need to keep babies in the hospital, then why keep them in the hospital? So another study found that within 24 hours, you identify 90% of true bacterial pathogens. From infants 0 to 6 months of age, it takes about 17 and a half hours for true pathogens to grow from the blood. And from the urine, the median time to sensitivity is 16 hours to positivity, and the CSF, it takes about 18 hours for a true pathogen to grow. So some places like Seattle Children's will consider discharging a baby, a febrile neonate, at 24 hours if the bacterial cultures are negative and the viral cultures are positive, but not for HSV. So this obviously has to be done in a center that has a rapid viral panel. You do a nasal swab and you get those results back within 6 hours. Do we have that here? A rapid viral panel or just a nasal swab and back to in the hospital? Okay.
But is normal practice like for community hospitals that don't have a dedicated pediatric one and have pediatric that doesn't have high volume? Is the normal recommendation still 48 hours?
Yeah.
Until culture results come back.
Yeah. So I don't know, a lot of places just do RSV and influenza, and then the full viral panel is just sent out. So in some places, in one place where I was working at rural Kansas, they had, and it was a pediatrics hospital, and they would do a nasal swab, and within 6 hours, you would find out if the baby had coronavirus, rhinovirus, influenza, paraflu, even chlamydia, bordetella, and yeah, do a full viral panel. And so you would know within 6 months of after the nasal swab was collected what virus the baby had, which is awesome. But those sort of things can be overused. All the viruses. So and this just kind of applies to older kids too, but when would you guys think it's a good time to send the baby home? What should the baby be doing before, or what should be in place, and what should the baby be doing before you guys say, okay, it's okay to go home now?
Drinking.
Yeah?
Eating.
Yeah?
Eating. Normal activity.
So, yeah, normal activity. Yeah, like a normal baby. So the baby appears well. They're tolerating keto, so they're feeding, so they're taking their formula. They can follow up with their PCP within a couple days, 2 to 3 days. And of course, everybody should agree with this plan. The family and then the PCP and whoever is taking care of them in the hospital, cultures should be negative. So if a neonate comes to your clinic with fever, what do? They come to your clinic and they have a fever. What do?
ER.
Yes, ER. Okay, if you receive a call from a mom, I don't know if you guys take mommy call or not, but a mom calls
Yeah, we
you.
take all calls, yeah. Yeah.
And says my baby has a fever. Yeah. And you're working in the ED, because you guys work in the ED, right?
Yes.
Okay. And you'll see the flu patients too, right? So you have a febrile neonate that comes into the ED. So what do you do? Yeah. You perform the full 7-day workout. And then you give your first dose of antibiotics and you admit. And if you are the admitting inpatient team, then you will continue the antibiotics or give them right away if they haven't been given. And you'll make sure that your pan cultures are done. When I was a resident, one time I was a senior resident and we admitted a baby from an outside facility and I thought that the blood culture had been done, but it hadn't. And my attendant was pretty upset because then if you go off the pathway and you're not sure what to do, but usually when that happens, when you've pre-treated a baby, you have to watch them off of antibiotics for a couple days, 1 to 2 days. But okay, and then so you make sure pan cultures have been collected and are in lab. And again, if the LP is not successful, don't delay antibiotics. So for our purposes, we will watch them for 48 hours here in this hospital. So if a neonate has meningitis, though, we will not take care of that baby here in this hospital. Why? Because, well, I don't feel comfortable taking care of that baby in the hospital because meningitic babies, maybe, I don't know, maybe unless they develop a complication, but meningitic babies can have impediments, so that would require the expertise of a neurosurgeon. They can have seizures and elevated ICP, so really they should be somewhere where you have an intensivist and you have an IV doc, you have a neurosurgeon just in case. And then all meningitic babies should have an eye and ear exam because bacterial infection in the tonsil, but really bacterial meningitis can cause tetanus.
They have a meningitis cure and diagnose them symptoms.
I think they'll go to Loma Linda. I don't know if I would feel comfortable taking care of a meningitis. Because we can't transfer to the NICU once the baby if the baby comes from home, right?
It depends. Sometimes they do some good, and they're usually pretty cheap. That's the problem.
And besides, you do need an ID doctor consult anyway. Length of treatment. Right back for meningitis, but still ID should be consulted. So.
This is probably a foolish question. Is pediatric ID?
Yeah, pediatric ID.
Okay.
So, what we could do here is we could come up with a pathway, just like how other hospitals have come up with kind of a protocol of how to manage a febrile neonate. Because other studies that I read actually show that a lot of pediatric ERs are not doing what's recommended. So a lot of them don't do the full sepsis workup and they send home a neonate that has a fever, or they send them home and have them come back the next day. So that's just been some of the reading I've done. So we could come up with some sort of pathway. We can define what do we want to be a neonate in our institution, 28 days or 30 days? How long should we admit for? We can see what resources we have. Do we have any rapid viral testing that would look at lots of viruses? Because studies have actually shown that if a baby, a newborn baby has a virus, their risk of a concomitant serious bacterial infection is very low. Bronchiolitis, though, is associated. Do you know what bacterial infection it is associated with bronchiolitis? So RSV is a virus that can cause bronchiolitis, but RSV bronchiolitis can also cause a concomitant is associated with a bacterial infection at the same time. UTI, otitis too, but UTI. So a bronchiolitic baby that's not getting better, you should check it and look in the ear. So remember, standardization improves medical care, so that's why we can have something to kind of standardize how we take care of our febrile neonates. I think that's it. Yep, more resources.
Really awesome.
Thank you.
That was great. This is Dr. Zargar's first lecture after